it is our great opportunity to have Professor H.Kim with us today. Professor Kim is a pulmonologist from the University of California, San Diego. So UCSD is the pioneer of CTEPH, pulmonary endotheliectomy since 1970s and has performed PEA for almost 5,000 cases with excellent outcome. 2 years training in public. And I myself also had a chance to spend time to learn from Professor Rerun and her team too. This experience inspired me to be interested in CTEPH. And in 2018, Professor Kim came to Thailand for giving us a talk, and with help from Professor Rerun from Rerun Hospital, I had a chance to meet Professor Kim at that time. And in 2019, I had a great opportunity to spend time with Professor Kim and his team in UCSD. And our CT surgeon also has been there too. Professor Kim has more than 100 publications, including being a first author of the 6th World Symposium on Pulmonary Hypertension on CTEPH section in 2019. So it is our great opportunity to have Professor H.Kim to come here to lecture with us today. So please give a round of applause to Professor Kim.
Thank you, Dr. Farah, for that very nice introduction. It's my pleasure to be here with you. I can't believe it's already been 5 years. Time really goes by fast since I first visited your center. Thank you for allowing me to come back. I also greatly enjoyed Dr. Padarin's time at UCSD. You guys are all very fortunate to have her here leading your pulmonary hypertension efforts. So I'm going to bring up my slides now. So I've been asked to overview chronic thromboembolic pulmonary hypertension diagnosis and treatment. I think I was given maybe 1 hour, but I think the slides will take maybe about 40 minutes or 30 minutes thereabouts. If you have any questions along the way, please do interrupt so we can discuss, and afterwards we'll have enough time, I think, to discuss other topics as well. This is no longer a simple topic that you can cover in just 1 hour. There are many things happening in this area, and I'll try to give you kind of a highlight of it. So here are my disclosures. So I understand there are both pulmonary and cardiology specialists in the room. And also various stages of learners. So in the U.S., for pulmonary hypertension, it's either oftentimes pulmonary or cardiology based. And at UC San Diego, we happen to be pulmonary. So a lot of the pulmonary hypertension work, we actually do our own right heart caths as well, which is actually very helpful. So even though I'm a pulmonologist, don't ask me anything about asthma, because this is not what I do. As Dr. Pad knows, I only do pulmonary vascular disease. So all these disclosures here are from companies that have helped us along the way in both pulmonary arterial hypertension as well as chronic thromboembolic disease. So we're going to talk primarily about WHO Group 4, and the principal diagnosis there is chronic thromboembolic pulmonary hypertension. And just so that we're clear, when I look at the classification table like this, for me, I only really see 2 diagnoses. I know it's a very complicated table for some, but to me, there's really 2 diagnoses. There's PAH and there's CTEPH. And I call these diagnoses because Group 2 and Group 3, even though they're the most common causes of right-sided pressure elevation, these are more mechanisms rather than disease. PAH or CTEPH, without proper treatment, these patients will die from right heart failure. So, but today I'm going to focus primarily on this condition, chronic thromboembolic pulmonary hypertension. This is a report that if you're doing pulmonary hypertension work, you should have some familiarity. I know this is about 10 years old, but this is still relevant today. And the main message here is, unless you do the diagnostic algorithm carefully, you can misdiagnose pulmonary hypertension. So this was a study looking at patients who were diagnosed in the community. Is there a translation going on? Or no? Oh, Okay. There's patients who are diagnosed in the community and then sent to high-volume academic PH centers. The main message is 40% of these patients actually had a misdiagnosis. So it's very important for centers like yourself to be a resource, I think, for other hospitals and other systems to derive, proper diagnosis, because the wrong diagnosis is going to set you off in a poor path. Dr. Potter reminded us about the pioneering work from UCSC back in the early 1970s, roughly. But prior to that, chronic thromboembolic pulmonary hypertension was diagnosed often during autopsy. This is a patient who succumbed from pulmonary embolism. You can see the fresh clot there. This is somebody who actually died from chronic thromboembolic disease. And this was usually a post-mortem diagnosis. The person who changed all that is Dr. Ken Moser. So he is the pioneer for chronic thromboembolic disease work. For those of you cardiologists in the room, you probably know Eugene Grunwald, a very famous cardiologist. He was the first chair of medicine at UC San Diego. San Diego opened in 1968, I think. And Dr. Grunwald recruited Dr. Moser to be the leader for pulmonary medicine. And he had already worked in Washington, D.C. with early, work on CTEPH, but once he came to San Diego, he really took it to the next level. I'll show you at the end of the talk some of my other current team members as well. So when we talk about chronic thromboembolic pulmonary hypertension, we recognize there's clotting problem, but it turns out this is not a recurrent clot issue. It's the failure of resolving the clot. So you have this chronic fibrous scar tissue. There's more work now being done with linked with inflammation and infection. But for the most part, for the last 50 plus years, the focus has been on trying to deal with this fibrous scar tissue. We know when our patients come in, they look just like pulmonary arterial hypertension in that they can have severe right ventricular failure. And we also now understand the small vessel component is quite complicated. So I'm going to hopefully touch on some of these aspects as we go. So we think it's related to acute pulmonary embolism. And thankfully, vast majority of patients after PE will resolve. So if you're wondering why don't we screen everybody for pulmonary or CTEPH after PE, I don't think it would be very cost effective. Roughly about 2% of patients after a major PE, we think, will develop CTEPH. And it's probably a combination of multiple factors, including the small vessel changes that happens over time. This was another consideration. So do patients actually go from acute PE to chronic PE and all the way to progress to CTEPH? We don't know if it's a linear, direct line, or is it the natural history. There was a recent publication from the UK group that suggested patients with CTED, many of them actually don't progress to CTEPH over time. So it may be that some patients are just vulnerable and will go straight to CTEPH. But this is an area that I think that needs further work. So what do the guidelines say about the anticoagulation aspect? So CTEPH patients, regardless of treatment, should all be on chronic anticoagulation therapy. So the European guidelines recommend anticoagulation with a low evidence, but they don't really differentiate vitamin K antagonists versus DOACs. So there are two papers I want to share with you that suggest maybe we should stick with vitamin K antagonists. The first one is out of UK. So the busiest endarterectomy center in the world is UCSD. Second busiest is Papworth. And in the Papworth series, almost 1,000 patients, you can see about 20% of them were treated with DOACs after endarterectomy. And when they followed them, there was no difference in bleeding complication, but the recurrence of VTE in DOAC cases were almost 6 times those of DKA patients. They didn't show any survival difference, but it did ask for or call for formal study to study this further. Around the same time, I had a visiting colleague from Korea do a somewhat similar analysis for us. And what she did is took cases of endarterectomy that was performed at UCSD and looked at the specimen. Actually, myself and one other colleague who specializes in CTEPH and pulmonary embolism looked at the specimen, and we identified these kind of specimens with fresher clots versus kind of bland CTEPH specimen, which is what we're typically used to seeing. Bottom line, almost twofold likelihood of seeing fresher clot in patients who were previously treated with DOACs versus VKA. So I think the two major centers in the world have some concerns about applying DOACs to every patient with CTEPH. However, when you look at some of the international registries and national reports, very consistent. There was no difference between DOACs and vitamin K antagonists. So I think the jury is still out. My question would be, what about disease-free survival, right? Because if they keep getting recurrent clots, that would potentially contribute some comorbidity and additional treatments. One last thing I will say about the acute clot to CTEPH is, does intervening early affect and prevent CTEPH? So the one paper that I think was somewhat definitive, I would say, is the PICO long-term study. So this was tenecteplase versus standard anticoagulation in patients with submassive pulmonary embolism. And when they followed them long-term, there was really no statistical difference in terms of CTEPH. I know there are folks who do catheter-directed lysis feel maybe doing mechanical intervention may alter this, but I still haven't seen convincing proof of that. So the bottom line, thrombolytics, we don't think actually can lower the incidence of CTEPH. Now I'm going to shift gears and talk primarily about chronic thromboembolic disease. And this is from the Fifth World Symposium in 2013. Just to highlight the difference, this is an angioscopic photo. We used to do this. We take a bronchoscope, a pediatric bronchoscope through a 11 French IJ, and we would stop the blood flow. And our chronic thromboembolic patients have webs like this, versus the bottom one, that's a pulmonary embolism. That's not what we want to see. And so you can see why this would cause narrowing in the circulation, and why removing it with endarterectomy may be very effective, and why maybe even balloon angioplasty can be somewhat effective as well. And at the time, our focus was suspecting the condition with V2 and echo, confirming it with hemodynamics and pulmonary angiogram, alternatively CT, or some centers are doing MR, and then immediately thinking about surgery. But things have changed a bit since then. In terms of what is the basic requirement prior to considering CTEPH, I summarize it right here. So if you have somebody with an echo that looks like this, true pulmonary vascular patient, V-shaped septum, blown out right heart, they can get pericardial effusions as well, and chronic perfusion defects, as you can see there, that's enough for you to start considering chronic thromboembolism. Now, I know people have gone away from nuclear medicine perfusion images, but for pulmonary hypertension work, I think this is still the best way of trying to discern whether somebody has CTEPH or not. And we're not just talking about any defects, especially the lower lobe, especially the right lower lobe for some reason is very common for chronic thromboembolism. You can see here in the right posterior oblique view, multiple defects here, similarly in the left posterior oblique. We often get referrals with patients with apical or anterior defects in the setting of lung disease, for example. Those are not CTEPH. So I know they can make things a little more complicated. But if you have somebody that looks like they have bad pulmonary arterial hypertension and have a perfusion image like this, it's CTEPH usually. These patients don't always have to have a VTE history. So in our series, less than half of them had deep venous thrombosis, and 30% of them never had a clinical history of pulmonary embolism. So key message, the absence of VTE does not exclude the possibility of CTEPH. And for those of you, again, working in pulmonary arterial hypertension, those patients could be identical to the CTEPH patients unless you ask the question, could there be perfusion defects? I want to brag a little bit about our program. This is our volume prior to the pandemic. So I took a team out to Japan to learn our balloon pulmonary angioplasty. After visiting them in 2012, 2013, we started early 2015. And you can see our balloon angioplasty program rose quite a bit. It did not take away from the endarterectomy volume. Even during the pandemic, so we did a maximum over 200 cases 1 year. We're doing about 185 even during the pandemic years. So roughly about 200 surgeries, and balloon angioplasty dropped off during the pandemic, but I think it's going to come back as well. So when we talk to our patients about surgery, we're often trying to figure out, could there be disease in the proximal vessels? This is actually a real cartoon that one of our nurses used to show our patients, to show them we want to find disease here and remove it during surgery and not the periphery. Okay. Unfortunately, the trying to predict microvascular disease is not a perfect science, and it often comes down to expert opinion, looking at hemodynamics or radiographic comparisons. For those of you less familiar with surgery, this may look very impressive to you, and if you're impressed by this meaty stuff here, I did this on purpose. It should be this stuff that should impress you. The main skilled surgery actually is removal of these obstructions down below in these peripheral vessels, not this chronic proximal stuff. Okay. And I'm blessed with having the two best surgeons in the world, and this is the other surgeon showing that they can do very detailed distal endarterectomy down to the subsegmental branches. And this is what really improves their pulmonary hypertension. So this is the intraoperative classification. This was revised some years ago by Dr. Megani and Dr. Pretorius. So now we have level 1 for main PA disease. This is lobar disease, level 2. Level 3 is mostly segmental disease. Level 4 is subsegmental disease. And when Dr. Potterin came and did some work with us before the pandemic, she presented this in the first year of the pandemic at ERS. So she looked at 50 cases going through surgery. It was roughly evenly split, men and women, mostly functional class 3. And we asked the question, how are the experts in trying to predict the level of disease? And in her work, you can see here, we were not very accurate. So these are the world experts in chronic thromboembolic disease, and we were only right, in some cases you see less than 50% of the time in terms of being precise about the level. Now when she compared grouping the proximal level 1, level 2 versus level 3 and level 4, we were a little better, but still under 70% accuracy. And the key message here is, even the experts cannot properly predict the level of disease. So please try not to do this prior to surgery. It kind of reminds me of, what we do with, let's say, surgical oncology all the time, right? We have the pre-surgical staging, and then we have the surgical staging. Well, the level of classification that the surgeons have introduced is more of a surgical staging, so please try not to apply this in the pre-surgical stage. The common thing that I hear all the time is they feel that a patient will have level 3, level 4 disease, therefore I'm going to start Riociguat and also do balloon angioplasty. That's, to me, incorrect. You worry they may have distal disease, and that's why, or the surgeon may think that that's too risky of a case, that's one thing, but you cannot label them with a surgical level without surgery. So this is the last World Symposia treatment algorithm, and I have the honor to direct the next one as well. So we're actively working on that now for the June meeting in Barcelona. This is the next World Symposium. And in the last one, the key introduction was this importance of expert CTEPH team. And we outlined here what a multidisciplinary team should consist of. There should be an endarterectomy surgeon, a PH expert who is familiar with, let's say, medical therapy and the management of bad pulmonary hypertension, balloon angioplasty interventionalists, and chest radiologists. Do you see this? I had to cover this here. This was very controversial. At the time, our group, this is an expert opinion group, we gave recommendations on the volume to account for expertise. And the steering committee at the World Symposium said, no, this is too controversial. At the time, we said over 50 endarterectomies a year, over 100 balloon angioplasty procedures a year. And some centers did not feel comfortable because that would discount them as an expert group. So that's why I covered that up, and they were happy with this. So this is a topic that's going to keep coming up because clearly in a rare disease, a specialized treatment, doing more matters, okay? And this is why hopefully in Thailand you're collaborating together to concentrate the experience instead of having too many centers trying to do not just endarterectomy for balloon angioplasty as well. The other key thing was these double arrows, recognizing that because the determination of surgery versus non-surgery is very subjective, we've had patients who had balloon angioplasty who would come, persistent pulmonary hypertension, and have endarterectomy at our center. And we have now many patients who had endarterectomy who later on will develop more pulmonary hypertension, will then go on to medical therapy and balloon angioplasty. I know at the time people were critical about this double arrow. It's kind of odd for algorithms, but this is the reality for CTEPH. It's a managed condition now treated across surgery, intervention, and medical therapy. The other thing that I advise we take out is you don't see a new line here going to transplant. So even though lung transplant is treatment still for pulmonary arterial hypertension, I think in expert centers we don't do this now for CTEPH because it's very manageable across 3 modalities. So we're now up to about 4,900 surgeries, so we're going to have a major celebration early in the year, 5,000 surgeries and 1,000 BPAs. Yeah, we've had patients this young, patients that old. On average, I would say about 55 years of age. No difference across genders. Our recent mortality is down to about 1%, as Dr. Pedro mentioned, but overall in the publication years ago it was about 2.2%. And our patients are staying usually under 2 weeks. Now, determination of surgery, like I said, is very subjective, and that's why I just pointed out these are not contraindications for surgery at our center. In addition to redo surgery, there's no degree of age. The 89-year-old, for example, was very active 89, who needed a bypass grafting as well, and he did fine. Obesity, we had a BMI over 60. Provided we think the chronic thromboembolism is truly a limitation for them, we would recommend surgery. Now, if a BMI of 60 has a TVR of 300 dynes, for example, with only a few segments, I probably wouldn't recommend surgery for that patient. But if that patient has a lot of major obstruction, they're never going to exercise to lose the weight, for example, right? And then we also operate on heparin-induced thrombocytopenia, sickle cell anemia, and even Jehovah's Witness patients. Here's another challenging case. I got called about this boy who was intubated after coming in with massive hemoptysis. It was 2,000 miles away. And, when you look at an x-ray like this, you can see, yeah. So it looks like there's a pneumonia here and here, correct? Well, that's the normal lung. The abnormal lung is here because that's not getting any blood flow. Okay, this is the normal lung. And we've had patients mistaken for, cryptogenic pneumonia who underwent lung biopsies for areas of normal perfusion. Well, for CTEPH, you have to think about the pulmonary circulation. So when I looked at his images, I saw clearly, and here's an example of where the normal lung is. And see, the right upper lobe is getting a lot of blood flow. So his whole cardiac output is going through there, and it's having hydrostatic edema there. And you can see his right heart is extremely in dire straits. So this boy is going to die. There's no point, of thinking about, I don't think he will survive transplant, et cetera, ECMO. So we flew him out here. Dr. Madani did endorectomy at the Children's Hospital. This may not look impressive, but we get this 2 months later. I don't know if it's playing. So we tell our patients, don't do anything for a couple months. No driving for a month. Wait for 6 months to recovery. For 2 months, he's already doing this. Okay? Yeah, it's a great story. I was so happy. Madani was so happy seeing it. On the other spectrum, this is an elderly patient with obviously pacing wires and AICD, etc. Very peripheral defects with this type of lung scan was very difficult distal endorectomy in addition to removing all this hardware that was the source of the blood clot. So, anyway, you know, it's very subjective. You're probably not going to take on these type of cases, but just to let you know, it's important to you know, review each case in a multidisciplinary fashion. I do want to talk about small vessel disease a little bit. So traditionally, we thought the small vessel disease was potentially distal clots or shear forces causing pulmonary arteriopathy. We didn't know how to exactly explain why arteriopathy occurred in areas of occlusion, but more recently, the French colleagues presented this theory in very sick CTEPH patients. They noticed that they had these collateral circulations from the systemic side providing blood flow to the pulmonary arteries, and that's another way, and probably is a better explanation of why the occluded areas have arteriopathy. So all three possibilities for causing small vessel disease. I would say the important treatment advances in the last 5, certainly last 10 years are summarized here. I mentioned a bit about the more distal endorectomy, especially at high volume centers, but we now have pharmacotherapies, balloon angioplasty, and combination modalities. So in the next 10 minutes or so, I'll quickly go through these advances. So worldwide, this is still the only approved medical therapy for pulmonary or CTEPH that's inoperable. And my understanding is you guys have this therapy approved here. So this is, again, about 10 years old now, but this is riociguat. For those of you not familiar, this targets the nitric oxide pathway. It's an SGC stimulator that even in the absence of nitric oxide can produce more cyclic GNP, which is the key second messenger. In the clinical trials, in a 2-to-1 randomization, you can see the treated arm had a much better and sustained 6-minute walk improvement compared to the placebo group. And when you look at the subgroup hemodynamic analysis, it was really driven by improvements in the treatment arm, not from deterioration in the placebo arm. That's important. These patients, by the way, were not on background pulmonary hypertension therapy because at the time there was no approved therapy for chronic thromboembolism. We've had other studies since then. This was the phase 2 study with macitentan. And in this group, we just looked at inoperable patients, excluding riociguat. And the primary endpoint was a PVR reduction. There was about a 16% better improvement in PVR compared to the placebo arm, which interestingly had a placebo effect as well, possibly from 60% of them having allowed to be on background therapy. But the key secondary endpoint at 24 weeks was an improvement in 6-minute walk distance. So this is not a approvable study, and so we embarked on a phase 3 study, which I'll summarize in the coming slide. In Europe, primarily out of Austria, they looked at subcutaneous treprostinil. So they're applying PAH therapies to inoperable CTEPH. And here, they took patients who were deemed inoperable. In this group, we're up to about 30 nanograms per kilogram per minute of subcutaneous, which is only 3 nanograms per kilogram per minute. And you can see the higher dose group had a treatment response when it came to PVR as well as 6-minute walk distance. And that's why this drug is approved in Austria and a few other places. In Japan, Pak Ogo led a small study with selexipag, which is an oral IP agonist, again used in PAH. and was able to show that in the treatment arm there was a PVR reduction and no effect in the placebo arm. And even though there was no 6-minute walk difference, for the Japanese regulatory agency, this was enough to get selexipag approved for use in inoperable CTEPH. So the bad news for the international community, however, is when the company Janssen, Kelly and Janssen conducted an international study with selexipag and with macitentan as well with a higher dose. Both studies, unfortunately, did not pass the early futility analysis, and both of those were halted. That's bad news for the community. However, I will say that has not stopped centers and providers who have access to these therapies, often utilizing pH therapies on an off-label basis in some of our patients. I'm going to shift gears now and talk about balloon pulmonary angioplasty. So 2012 was an important year. Balloon angioplasty was first reported in a major series out of Boston in 2001. Few patients seemed to benefit, but there were some major complications, including a death and 60% complication rate. But the Japanese in 2012, 3 centers presented improvements both in the results and the safety of the study. And this is a nice OCT video showing you why this may work. Here are the fibrous scar tissue. You can put a wire through there and basically rip it open, and you can see a normal vessel distal to that. I know you have BPA here. This is another example applying coronary FFR. It's not the same, but you can see a reduced FFR that improves after balloon angioplasty. This is a nice example where the pulmonary angiogram can be misleading, right? It looks like this is an intact vessel, but in fact there was a lot of narrowing there. You can see the pressure gradient improving after balloon angioplasty. So FFR or pressure gradient is not something that's routinely done, but some centers rely on this currently. So here's an example, selective angiogram showing defects, balloon dilation, and then after dilation showing improvements. The key is not the arterial phase, it's the venous phase. You see this brisk venous return? This is what we look for, not the maximal dilation of the arterial phase. That's part of the reason I think the Boston group had complications. And here's one of the complications. This is not from our center. A major vascular injury, usually hemoptysis, lung hemorrhage. And the classification of complications there's not a clear consensus, but these are some of the problems. I think if you look at the early reports, especially back in 2012 from the Japanese, they chose the wrong definition, I would say. They kept saying reperfusion pulmonary edema. This is not reperfusion pulmonary edema. Reperfusion pulmonary edema is really more to describe the SIRS-like response after endotherectomy. The injury that they get with balloon angioplasty is more vascular lung injury, often presenting with hemoptysis. Most recently, this last year, we saw 2 simultaneous publications in Lancet Respiratory Medicine, one from the French, the RACE study, and the other from the Japanese, Mr. BPA study. Slightly different studies. In the French study, they took patients who were deemed inoperable with their MDT and randomized them either to riociguat first line or balloon angioplasty first line, and then 6 months later, if they're not improved, did a crossover analysis. At the end, they had an initial better response with balloon angioplasty, but more complication rate. And when you follow them long term, they achieved about the equivalent PVR reduction. So that group is advocating for, in patients with bad pulmonary hypertension, treating with medical therapy to improve the hemodynamics, then follow them with balloon angioplasty. The Japanese Mr. BPA study looked at mean PAP as the primary endpoint. And at 12 months, they showed a much bigger reduction in mean PAP with BPA versus riociguat, which is not surprising, right? Because you're doing a mechanical intervention versus pharmacotherapy. But if you do BPA first line, there was a higher complication rate. Artie Goswami and I had an editorial comment to this publications, and you can see here when I summarize
See, they defined it slightly differently in the two papers, but in the end, very similar results, I would say. Roughly 40+% when you do BPA, prior to medical therapy, had vascular injury. When you did riociguat, a much lower complication rate. I'm happy to share with you some of the preliminary work from the ICA BPA registry. This was a registry that I started through the International CTEPH Association. So the question I asked was, a lot of people were calling the complications differently, and depending on where you learned, they were doing things differently, right? You have centers who rely on interventional cardiology versus other centers doing it more through interventional radiology. They have different definitions or different ways of imaging and different criteria. So we took the 4 top centers in Japan, including Okayama, Osaka, and 2 centers in Tokyo. The European centers, 9 of them, they had a lead start before the U.S. centers, so us and 4 other centers in the U.S., so 18 centers in total. So these are experienced centers doing BPA. And this was recently presented at our ICC meeting in San Diego. This is still unpublished. We had over 2,300 procedures and 484 patients where we have follow-up. And you can see here over 70% of them were deemed technically inoperable. You see 13% had endarterectomy with residual pulmonary hypertension, and so on. And this is the other slide I wanted to share with you. Roughly about 9% thoracic complications, most commonly vascular injury. So you just combine these two here. So you can sometimes have lung injury without hemoptysis. Usually hemoptysis is just a more serious complication of that vascular injury. The key finding here is no patients died. And so I think this is reflection that we picked the experienced BPA centers, because many centers in the early years, including the Paris Center, that is one of the busiest in the world now, had some mortalities. But in this series, we've had no mortality. So this is a publication that is currently being worked on, so hopefully we'll share it with you soon. This is a publication that was from the last ICA registry. So originally there was the international registry that's been published years ago, more recent one that was published since the BPA started. And I'm going to just summarize some of the findings from this more recent registry where we included centers who are doing BPA as well. These are over 1,000 patients. So in red are the Japanese centers, and we separated them because their approach to CTEPH treatment is heavily BPA-based, whereas in the U.S., Europe, it's mostly endarterectomy-based, as you can see there. And there are a subgroup of patients who did not receive any intervention, and those patients, not surprisingly, had a much higher mortality than patients who were treated with one of the interventions. And here's some of the findings. So the blue line are overall mortality from the endarterectomy group versus the red line in the BPA group, and patients who were not treated with either intervention in the medically treated group. But interestingly, when you separate out riociguat, which is the one approved therapy that most of us are using, they did much better in terms of overall survival than patients who were treated with other off-label therapies, most commonly PD-5 inhibitors and ERAs, for example. So this is a very nice kind of latest result showing how patients who are inoperable are actually doing much better than in the years past when you follow guidelines and when you do evidence-based therapies like medical therapy with Rio and balloon pulmonary angioplasty. So this is a summary slide, my last slide, before I conclude and open up for discussion. So this is kind of where we are. We have the 2 interventions, and we have the medical therapy. I would still argue that for chronic thromboembolic patients, which is defined by mostly scar tissue from old pulmonary embolism, the treatment of choice still is endarterectomy, and that removes the obstruction. It's one-time surgery, and roughly about 2 weeks in the hospital, maybe a month or 2. You saw the video of that little kid jumping around in 2 months, but it can take a few months for recovery. The mortality should be under 2% roughly at experienced centers, but I reckon recognize, we all recognize, it's a difficult ask for many countries, especially with limited access to experienced surgical team. And I'm glad that you have a surgeon here who trained properly and hopefully is getting regular cases, but the access is quite a challenge, I would say. Balloon angioplasty, these are reserved for patients who are not endoatherectomy candidates, and this primarily lowers the pressure, but multiple sessions are needed. I didn't mention there, on average, 4.8 sessions in that ICA BPA registry. Some patients need more than 10 sessions, for example. Even though we had no mortality, published mortality up to 3% from serious vascular injury, it does have a steep learning curve, so I'm glad that your colleagues here are taking the right approach and learning this properly before applying, because just because you have great interventionalists doesn't mean you can do this safely, because the pulmonary circulation is very fragile compared to other systemic circulation. And then with medical therapy, obviously the access is usually widely available. It drives cardiac output primarily as the path for lowering PVR, and it's overall pretty well tolerated. So to summarize, please think of CTEPH for any patient with pulmonary hypertension or history of VTE who presents with dyspnea. Unfortunately, even in the U.S., about 2 years often goes by before somebody gets properly diagnosed. This is a manageable condition now with multiple effective therapies. Over the years, I have toned down the comment that this is curative with surgery. Few patients are, but most patients, if you follow them, may have persistent pulmonary hypertension, and now we have other modalities to treat them. And thankfully, the inoperable CTEPH, whether they had prior surgery or not, are doing much better. But the reports are primarily coming out of high-volume centers who do very careful multidisciplinary review. And that's my last comment. I think the best state-of-the-art management requires a multidisciplinary team. And I know Dr. Patterain recognizes many of my colleagues here. So this is our CTEPH MDT team. So I lead the pulmonary vascular attending. So David Pot, Jenny Yang are two of my colleagues who do balloon angioplasties with me. They trained to do this, and then we've been doing this almost 9 years now. We have other colleagues in pulmonary who do pulmonary vascular work, so there's 7 of us rotating on the pulmonary hypertension service. We have Dr. Madani, Dr. Pretorius, the 2 best surgeons in the world, I would say, doing pulmonary endoatherectomy. We have Dr. Mahmood, who's the head of cardiology and head of interventional cardiology. Dr. Ang, who would do the balloon angioplasty. So they're the ones that actually do the ballooning after we do the right heart cast and setup. And we have Louis Han, Albert Sue, who are the 2 chest radiologists who work with us. So if you ever have a chance to visit us every Friday, we get together and review all our cases. Thank you very much. I'll stop there and answer questions.
Okay, so we have our audience, please. Can you speak with the microphone, please? Because we have the audience online as well.
And please, online audiences, please, any questions or comments, please? Push the button. Yeah. Oh, not working.
So greetings, we have a first year medical residency, and actually like from what you talked before and from what I understand, you for the patient with CTEPH in the pre-surgical stage, you did not recommend us to like classify them into the surgical order. Is that correct?
I'm sorry, so the pre-operative phase, yeah. Classify them how?
Like you actually mentioned that we should not like classify patient into like segmental or subsegmental, before?
Oh, no. Yeah, I'm glad you're asking that. So I don't know if you guys heard, but in the preoperative phase, do not classify them as segmental or subsegmental. I think it's perfectly fine to discuss, the anatomic location based on your radiograph. My point is do not use the surgical classification, because this is only reserved for after surgery. And in fact, even our chest radiologists, I've had one of them, I have to explain to them because they summarize the report based on a CT, level 3, level 4 disease. I said, no, you don't know this. Again, based on our study, and we did another study after Dr. Patterson left, working with our chest radiologists, and their results were not much better than the CTEPH experts. So, yeah, I think we can still call it based on radiograph or describe it anatomically, but please do not use the surgical levels. Thank you. Because, what I find troubling, and I've actually corrected my colleagues in this as well, is some people justify, I'm not going to say which ones, we cannot justify balloon angioplasty or medical therapy based on what we think the level is, because you're not going to know until the surgery. And what we saw was surgeons often find much more proximal disease than what the experts thought, and vice versa. Sometimes we think somebody's going to have very proximal disease, but when they go in, they find extremely distal disease. Thankfully, our surgeons are skilled enough to do the distal dissections, but yeah, it's just, hopefully I made that point clear. You should not use that level classification without surgery.
Professor, in cardiology, we have some kind of treatment for like a bridging before the surgery. For example, we have aortic balloon angioplasty before the surgical valve replacement. So for the CTEPH, is there any role for the BPA for the bridging before the endarterectomy?
Yes, excellent question. So the question again for the online audience is, is there a role for balloon angioplasty prior to, let's say, endarterectomy? The simple answer is yes. I shared with you UCSD approach, which is, we're the most aggressive with surgery, partly because it was pioneered at our center. We do the most surgeries. So it's understandable, I would think, that we would be the most aggressive. So we take, in the very high-risk patients, we still prefer endarterectomy first, and then after recovery, consider balloon angioplasty medical therapy. However, other centers, for example, the Paris Center, one of the high-volume endarterectomy centers, they have used the approach of doing usually balloon angioplasty in the severe cases first, oftentimes in the left pulmonary circulation. Because as I mentioned in CTEPH, it usually affects the right more than the left. And so they've done balloon angioplasty on the left and then do endarterectomy later on. And then Germany, Bad Neuheim, which is another major center, they've even done hybrid, simultaneous, usually endarterectomy on the right side, balloon angioplasty on the left side, in the OR. However, only 3 cases they've done this, and I don't think they've done many more. I think it was more of a feasibility than a practical approach. So to answer your question, the answer is yes, but there's no uniform what first. If you're at a high-volume endarterectomy center, oftentimes we still prefer surgery because, again, when the surgeons go in, they often find more disease. And so in many of our patients, especially with the wide geography from our referral, they don't want to come back multiple times for balloon angioplasty, so they'd just rather have it all done. But then we also have patients who are reluctant to have surgery, and if there's balloon angioplasty options, they prefer that as well. So I hope that answers your question. It's not just one way, but there is example of doing BPA followed by surgery. One last thing I will say, our surgeons do feel that if you do balloon angioplasty and do endodorectomy, the specimen can be challenging because the specimen sometimes can have disruptions when they do the endodorectomy because, you know, the plane that they're doing the surgery is along the media. So all the intima, portions of the media come out. And with balloon angioplasty, they're rupturing and injuring the vessel. So sometimes it gets stuck where they do the ballooning. So it's still a controversial topic. So, yeah, thank you for that question.
So there is only the tunica adventitia remaining in the vessel, right? Because you remove the intima and the tunica media.
Yes, we think over time the intima will recover, but the surgery, the way our surgeons do this, is it's endodorectomy plane here. Again, this is on purpose. I wanted to distract you. This is not what's important, all that big clot. What's important are the distal branches that can be removed successfully. But somebody like this, ballooning is not going to work. I hope you can appreciate that. Ballooning is not going to help this type of case. Now, when you have somebody with potentially distal disease, I think ballooning and distal endodorectomy is competing in this level 3, level 4 class. But as I mentioned previously multiple times, we have to be careful. You don't know exactly what level they're going to have.
So it is important to have multidisciplinary team to discuss before you decide to treat the patient. Is that what you want to say?
Yeah, and thank you for that, because I do want to point out, so the comment was it's important for the MDT team. Absolutely, because all the data that we're getting are from high-volume centers who utilize MDT. So you cannot necessarily translate this type of excellent survival to non-MDT practice. Does that make sense? Because if you take somebody with clearly operable disease and you put them through some of these therapies, I'm not sure you're going to get the same results. These are results coming from high-volume centers where they've carefully done an MDT analysis and put them through what they thought was appropriate line of therapy. So if you follow that and you do have the MDT here, hopefully you'll get similar results.
And do you have any suggestion for us as beginning the CTEPH treatment? Do you have any recommend for us to do the MDT, to form the MDT team?
Yeah. You know, I've made analogies to lung cancer, for example, right? If you have a lung cancer diagnosis, you're not alone going to decide on treatment. Often it goes through tumor board. And when you go to tumor board, who's there? Well, you usually have, oncologists, you have radiation people, you have pathologists, etc. It's a multidisciplinary review of each case. We followed a similar analogy for CTEPH. So every week we have all these individuals or representatives of these individuals look at individual cases. And even though we're heavily surgical center, our BPA business is flourishing because, again, this is more of a chronic managed disease. So going back to your original question, I think the best first step is for you to identify an MDT group, at least in a representative from chest radiology, an interventional colleague, your surgical colleagues, and review the CTEPH cases that way. And I would say this will put you in the lead in terms of a national CTEPH referral as well, because this is the current state of the art. So I know Thailand has got many people, and you're going to have many patients suffering from this condition. Instead of having multiple centers trying to do 1 or 2 cases a year, it's better to have 1 or 2 cases a month or even more at a dedicated center. I'm sorry if that's more work for you, but that's the best approach, I think, for your patients.
So we have CT session with us today. You want to share any experience with PA in our center? Actually,
Thank you. Good to see you again. Thank you. No, thank you. Thank you for coming.
Yeah, we try to start our program here, but we have some difficult. Beginning with the test, number of tests, we have limited tests, and when we have limited tests, I also have a limited experience to build on. You know, I saw a lot, but in terms of the surgery, we need to like more experience hand-on for the real patient, for our patients. So we need more tests, in my opinion. So the better way is start the MDT and so build up and other centers see us that we are better, so they can feel better to send the patient for us. So I think it's going to be the best way in the future. For the past test that I done, I think, like you said, that we have difficult in terms of see the determine which patient is better for the surgery, because for the level 3 and 4, in my experience, I don't think that I can do it very well. So I want to do it only 1 and 2. But like you said, that it's very difficult to see the CT before the operation. But yeah, we don't know that when it go in and we cannot do anything because it's like a level 3 or 4. So it's going to be harm for the patient. So this is, I think, it's a very big challenge for us. That how to we determine that which case is the best. If the left, if you lot of course in the proximal PA, it's going to be easy. Yeah. So if you cannot do anything, it's like maybe the tapering a little bit in the level 3 and level 4. Yeah. It's going to be challenging. That do we need to do surgery and get in and cannot do anything? You know.
Thank you for sharing that. I think so. If I understand it right, the limitation of cath lab is just the cath labs are too busy with other cardiac caths. I mean, one consideration, I mean, you need right heart cath hemodynamics, but I wonder one thing you could do is have that done at the referring center, was one option. In terms of the imaging, I just brought this level up because, you know, I forgot to mention, in general, CT pulmonary angiograms are going to pick up the level 1, level 2. So, you know, with CTs, especially now with multi-detector CTs, and now we're going to have photon CTs and other CTs, you're going to probably reliably pick up more of the proximal stuff. These patients sometimes get missed, the level 3, level 4 on CT angio. In fact, one of our radiologists read a report said, no evidence of CTEPH, and I said, don't do that, because you know, we're ordering the CTEPH because we think they have CTEPH. It could be just very peripheral. But, you know, some of our radiologists are very sure about what they're seeing. But, yeah, I think for your practice, I agree. If you see a lot of more proximal stuff on CT angio, and let's say their hemodynamics are not so severe, those are the ones that hopefully you can build up your experience, absolutely. But I think, I don't know if, how the referrals work at other centers along in your area, but within the PH community, the concept of MDT for CTEPH is not new. So I can't imagine every PH team is going to have CTEPH expertise, right? I think you guys are probably in the lead on this one. So I would advertise that and see if you can get more of those referrals.
For the managing steps, we have one case which had BPA before PEA, and I think you want to share the experience. It is not good because I think it is more difficult to do PEA after BPA.
Yeah. Yeah. right. Yeah, this is what Michael and Victor share with us as well. It's anecdotal, only a few cases, but we have to listen to what the surgeons are telling us. And it's not surprising because BPA does a lot of potential injury to the local vessels there. So I imagine the plane is difficult to get. Yeah. No, actually, the surgeons there at Dr. Fidel supports that because primarily they're doing BPA on the left side and he's doing the endarterectomy after. So, that center also has now the most experienced BPA operator with Dr. Brunel, as you know. So they have a very big experience with BPA. So, again, expertise matters as well. So maybe they're getting really effective results with BPA, in lowering the hemodynamics and then allowing for surgery. So, yeah, there's no one right way. I think we take the opposite approach. Our surgeons we try to do surgery first and then recover them and then do the cleanup with BPA afterwards.
Yeah. I think it's about the time for lecture, 1 hour. Are there any questions from online? มีคำถามจากออนไลน์ไหมคะไม่มีเนาะ So I think we will close the online session, and after this it will be the discussion of our CTEPH cases because the patient concealing care duty, so we have to turn off the online session, but we do the record. If anyone wants to watch it again, we can give you the record. So thank you for the online audience to participate with us. So right now, เดี๋ยวเราปิดเซสชั่นออนไลน์นะคะ
Thank you.
So to start, so right now we are in our room only. So I think we should start with the cases. So we start with the potential for PEA patient test. So the first one would be 199